Hi, my name is Dr. Ross Hauser. Appreciate you guys watching. I also appreciate your questions. So we're going to try to have me do some videos on common questions. So today we're going to talk about questions that we've gotten from you guys. And some of the more common questions that recently we've had is, what is cranial cervical instability? What is lateral overhang of C1? Do you treat C0, C1? When do you use guidance for treatment? Why don't you use it for every injection? So this is me with our Turner system, our Turner mini C-arm, so it's awesome. It's not very big. Mr. Turner, who's the developer, he's awesome. You know, he just made equipment for the common local doctor to have in their suite that you don't need a lot of space for, and the radiation exposure is literally almost zero. It's almost zero. So you could see me using it here, and I'm using it for the top vertebrae. Cranial cervical instability, basically the definition is that the head supported on the upper cervical vertebrae, the bony attachments are not stable, meaning that when the person does all their various activities, the ligaments are not supporting the bones, so the bones move in destructive ways. So all the joints of the body have a little bit of play, but like screws on a hinge, whenever you see that you're opening the door and the hinge is jingling, it's not good. It means that there's a screw loose, and the only thing you can do to cure the problem is you got to get a screwdriver and tighten the screw. So when the ligaments in the upper neck, specifically the capsular ligaments that attach the occipital condyles to the superior facet of C1 and the facet joint of C1, C2, when those ligaments get stretched out, then as a person goes through different motions of their neck and head, the bones move in positions that they're not supposed to. So I just call that destructive bone movement or destructive joint movement. And unfortunately with that is because the vagus nerve, the jugular vein, basically sits on top of the vertebrae. When the vertebrae move in positions that are not supposed to, it can damage the vagus nerve, or it can impair, block nerve transmission, and that can even happen in the spinal cord. It can cause blood flow into the brain and out of the brain to be affected, to be compromised. And once fluid flow into the brain is compromised and nerve flow into the brain or out of the brain is compromised, a person's going to have a symptom. And if it goes on long enough, that symptom ends up to be a diagnosis. Anybody who follows me knows that I believe the main structural cause of human disease is ligamentous injury. It's joint instability. You can get joint instability in any joint, and that means the C0, C1 joint and the C1, C2 joint. So anybody who's an experienced injector over time can learn how to do injections safely without X-ray guidance or ultrasound guidance. So for most of my career, if you want to say half of my career, I've been doing prolotherapy for 30 years. So let's say for the first 15 years of my career, I didn't use any guidance. Now you might say, well, how did you know what to do? Well, what I did was, at Loretto Hospital in Chicago, for anybody who knows that, way back when in the mid-1990s, I was the director of the pain clinic there. So they had a C-arm, so I did all kinds of injections under C-arm, so I saw exactly where the needle goes. Because the charge to the patient, and this is a key point, the less time it takes the doctor, the less the charge for the patient. So when a doctor does prolotherapy in the neck and they gotta use imaging for every single injection, of course it's going to cost a lot more, because it's so much more time. So a doctor who takes 5 times as long doing the injections as Dr. Hauser, they're probably going to get a charge that's 5 times what I charge. So one of the things I wanted to do was to make the cost of the procedure as little as I could, as safe as I could, but as little as I could for the patient. So one of the ways I did that, I learned how to do almost all the injections without guidance. Now, I would use guidance obviously in the upper part because you need to know where the vertebral artery is. So that's why often, well, when I first treat a patient, I use ultrasound guidance, not x-ray guidance, because I have to see where the vertebral artery is, because you could hit the vertebral artery with the needle. So I'm going to have Izzy get me the model that has the vertebral artery. Remember, the vertebral artery runs in the transverse foramen in vertebrae number 2 to number 6. Then see how the vertebral artery runs along the atlas. So when we're talking about a person being in this position, this is basically their anatomy, and the chin's duct. So basically, I'm looking at this. So with the ultrasound, I need to know where the vertebral artery is. So I need to know where the vertebral artery is. Does that make sense? So when we're doing the injections, and always know somebody who's skilled at Hemel-Hackett prolotherapy or Hemel-Hackett-Hauser prolotherapy in the upper cervical region, then the injections are primarily periarticular. They're into where the ligaments attach to the bone. So the emphasis is on the outside of the joint versus the inside of the joint. A little bit of the solution goes inside the joint, but the pain and the disability is because the ligaments are loose and the ligaments attach to the outside of the joint. So that's another reason why, as long as somebody knows, C2 to C6, see how there's no artery there, right? And you see the artery up here. So you don't need guidance from C2 to C7, but you could see C0, C1, C1, C2. See how the artery's there? So that's kind of a key point. What we do in the office for a new patient with chronic neck problems that are severe enough that you're going to see a prolotherapist, we do a cone beam CT scan, then we do a digital motion x-ray. So we're basically seeing the anatomy in three dimension. And you could see here clearly C0, C1, C1, C2. So this would be one of the joints that we're treating, and that's going to be one of the joints that we treat. In this particular person, you could see that the occipital condyle is actually subluxed off the end of C1. So this person definitely has some C0, C1 instability. Then if we look at this one, this is C1, C2. See how this is angled here? See how this is angled? The occipital condyle is like a ball. See how it's a ball, right? So think of a ball, a golf ball on a tee, like a golf ball sits on a tee. So you would agree, every golfer puts the tee perpendicular to the ground and puts the golf ball on there. You would never want to have the tee angled and the ball's on there, because during the swing, the ball could fall off. And that's going to be a stroke. You're going to get charged a stroke. If you're going there and the ball moves, that's a stroke. So here, because this is angled, then this person has some instability. This has some instability. So one of the measurements that we sometimes do in the office is called the C0, C1 angle. So see, on this particular patient, the angle is only 18 degrees. So in other words, the occipital condyle on the facet joint is angled a little bit. But see this one, see how much it's angled? It's 44 degrees. So this particular patient, they have such a forward curve. If you have a normal curve, C1 facet joint is like a T in the ground. It's perpendicular. Then the occipital condyle fits on it just like a T. So it's stable. Well, you can imagine if as the C1 goes forward, the facet joint goes like that. Now it's an unstable situation. It's an unstable situation. So it would be remiss to just do prolotherapy. Like you could do prolotherapy, which is going to help, but you really got to get the curve good and you got to get the anatomy good. So that's why in our office, we emphasize alignment, curve, prolotherapy, not just prolotherapy. And then lateral overhang, this is at C1, C2. So as you go like that, does the C1 joint go over C2. Somebody doesn't have to necessarily get a digital motion x-ray, though we believe that's the most sensitive test. You could just get an x-ray in neutral, and then when you're tilted, and then have the chiropractor or the doctor look at that. So I did want to show a little bit of an upper cervical procedure, not the whole procedure, but just highlights of it and how we use guidance. Now we're actually going to watch a prolotherapy procedure, and then I'm going to explain what I'm doing. So this is actually this patient's first procedure, and he has some nitrous oxide to keep him relaxed. And then the first shots I do are 2 finger breaths from the spinous processes. So this would be the transverse processes. And basically I'm trying to hit all the transverse processes without tickling a nerve. And then eventually you'll see me work in, and those are injections onto the capsular ligament. So I'm still doing the transverse processes. I'm hitting bone with each injection. And you can see I'm doing 1 to 2 cc's per injection. And I always have my fingers here so I know where the midline is. So, and the needle angle is not going toward the midline, it's going parallel to the midline. Right, so I'm seeing where the spinous process is, and I'm 1 finger breath from the spinous process. You know, doing one capsular ligament attachment, the next capsular ligament attachment, the next capsular ligament attachment. And you can see the patient's very relaxed, so he is breathing nitrous oxide. Yep. And then I also am going to know where C2 is. So the injections are going to be below C2, above C2. I'm going to use ultrasound. So I'm getting the ultrasound ready. This is the occiput. This is the atlas. So now I'm going to do atlas injection, ultrasound guided. So you're going to see the fluid go in. So you can see the fluid go in. So I'm hitting the atlas. Then this is C0, C1. That's C1, C2. So the next injections would be C1, C2. You're not going to see all the injections, but then I would do some more at C2, C3, C3, C4. Then what I wanted to do on the other side, when we get to the other side, is I wanted to show you where the fluid goes, because that's very, very interesting. Okay, so now I'm getting ready for the other side, going to get a new syringe. So again, the other side, the occiput, then here's the atlas here. And then I have the color Doppler on, so you can see the fluid going in, see all that fluid going in, so it goes all over. So whether you do dextrose prolotherapy, other non-cellular proliferants, or use PRP, it goes all over. So even when you do an atlas shot, it's going to go, the fluid's going to go to the C0, C1, C1, C2. Then of course I'm going to also do the C1, C2. Now I wanted to show you with fluoroscopy where the needle goes. See, the needle's going to bone, and then when I'm injecting, the force, you'll see the force of the needle. So I hit the bone. You know, the facet joints are here, so you'll see all the spot welding, spot welding, spot welding. And this particular patient I know is very healthy, very health conscious, and she takes a lot of herbs, vitamins, exercises a lot, and you can see how thin her blood is. That's normal. Good example of doing prolotherapy of the neck with anatomy guided, fluoroscopy guided, and then of course ultrasound guided.